If you are okay, let's start this session. I am hopeful that this wouldn't be as long as other ones. I have a few slides that we are not going to discuss a lot. So, you know, when chronic kidney disease, when chronic kidney disease advances, at some point we don't have enough GFR to sustain our metabolism, meaning that we are making hydrogen, we are making acids, but we cannot send them out, or creatinine goes up, or BUN. We need to replace the kidney. In the past, we called it renal replacement therapy, which it is still here. These days, we say nothing can replace the kidney. We will call it kidney support or renal support therapy, whatever we call it. We are talking about this machine that is behind this. This is a dialysis machine. So I just wanted you to know this is not for USM, for the fun of it. Should we use kidney or should we use renal? Believe it or not, I think we nephrologists, we have more time that we need. So we fight over things that might not be that important. So there is a big discussion in the literature. Should we replace renal with kidney? Because many patients do not understand what renal means. So it is more patient centered if we use kidney instead of renal. Instead of renal stone, saying kidney stone. Renal. I personally am against it. The patients do not need to know about it. This is for medical school and for us. But just wanted to tell you that there are some people, how renal is the kidney or whatever, whatever. If you are interested, you can Google it, and there is a lot of things. We nephrologists are good about talking about nonsense. Another thing that I think for some reason, yeah, is we call it renalism. Have you heard of renalism? Like communism? Renalism is something that you will encounter in your life. So what it means is that, sometimes out of the fear of hurting the kidneys, we do not do the right thing. We call this renalism. What I mean is that a patient comes with major chest pain. I do an EKG and he has ST elevation MI, right? STEMI. This patient at imminent risk of death because arrhythmia and death, right? With STEMI. Then they say, hey, he has chronic kidney disease. Should I give him contrast? What? You should. Do you want him alive with bad kidneys or you want him dead with good GFR? Right? So renalism talks about this. So it is actually nephrologists are a good part of it, but I have noticed that interns and residents in other specialties are very worried about the kid. They are surprised. They are just can't believe their ears when I tell them, yeah, use a lot of contrast, see what the deal is. We need to know what is going on in the coronary artery of these patients. Because so if you want to read about it, this is funny. Again, it is not for US7, it's not for the things, it's just for the fun of it. So that's why I think I put the things wrong. Just wanted to tell you that here we call it kidney replacement therapy. For that reason, I told you that they want us to not to use renal. You wouldn't believe, but these days when I submit an article to a journal, sometimes they send it back to me and say, change all renals to kidney. The editors are very big on changing it to kidney. Anyways, these are the learning objectives. You read on your own. Let's go to a case as always. Sorry. Mr. Smith, 41-year-old librarian, has biopsy-proven IgA nephropathy that was diagnosed 15 years ago. Comes to see you in the clinic for regular follow-up of his stage 5 CKD. Do you remember I told you CKD is the final destination of many of these diseases that you have heard, IgA nephropathy being one of them. Okay, he tells you that he feels tired the majority of the time, even though he does not do anything more than usual, has decreased appetite, and has lost 5 pounds since last time he saw you about 2 months ago, and often has a metallic taste in his mouth. Today, he's asking if it's time to start renal replacement therapy for him. What is renal replacement therapy or kidney replacement therapy? It replaces the non endocrine function of the kidney. In other words, It cannot give you erythropoietin. It cannot give you renin. It is the filtration part that it takes care of. Okay, in patients with renal failure, meaning that it extracts the waste products, corrects acid base, fluid removal, electrolytes, and all those good stuff. All modalities of renal replacement therapy exchange solute and remove fluid from the blood across. Basically, while I'm reading it for you, I'm going to tell you I have a filter here. On one side, I pass the blood of the patient. On one side, I pass good fluid that doesn't have high BUN, doesn't have high urea, normal potassium, normal magnesium, normal dextrose is passing. And then I let the exchanges happen between the two. Basically, between a semi-permeable, it is not fully permeable because everything will go to the other side. Semi-permeable, so some of the things that I want to exchange will be exchanged between the blood and that fluid. RRT does not correct the endocrine things. So erythropoietin and vitamin D and all those will still need to be given to the patient. So basically, that's renal replacement therapy. We use that to replace the non-endocrine kidney function. Okay, it is used for management of renal failure. But if you think about it, when we say renal failure, please. Yes, yes, it is recombinant. Erythropoietin is recombinant. Yes. So, what are the types of renal failure? Basically, in these situations, kidney is failing, kidney is not doing its job, kidney is not doing the filtration. If you think about it, you know already about acute kidney injury. Many of them do not recover on their own. Many of them never ever recover, actually. They will end up being on dialysis. So it's an abrupt, you know about the decline in GFR. So it can be acute on chronic kidney disease, meaning that somebody already had chronic kidney disease, now gets some aminoglycosides, get acute on chronic, or somebody has had normal renal function, gets acute kidney injury. The point is that depending on the severity, they may or may not need to get dialysis. Chronic kidney disease, however, is the form that is a little bit, I would say, chronic. We talked about 3 months needed to make the diagnosis. Then over time, over the years, they end up GFR goes little by little down until they need dialysis, until they have symptoms and signs that it tells you maybe it's time to start dialysis. So let me ask you a question about the previous lecture. What are the two main factors for progression of CKD? Hypertension is number one, exactly. Proteinuria, second one. Very, very good. Excellent, excellent. So we call these patients end-stage kidney disease, those who go from chronic kidney disease to end-stage kidney disease, that there is no way back. What are the indications of renal replacement therapy in AKI? So I have a patient has come here with sepsis, hypotension, gets acute kidney injury. He's in the ICU. The creatinine 1, 2.5, 3.2, 10.8. When do I start dialysis? I look at this. AEIOU, intractable acidosis. The acidosis is major, 7.2, 7.23, and I give him all the bicarbonate in the world. It's not going anywhere. Time to start dialysis. Major hyperkalemia. I'm worried about arrhythmias. I start treating the hyperkalemia, treating hyperkalemia. I'm going nowhere. Time to start dialysis. Intoxicants. And when we talk about intoxicants, these four you need to memorize. These are the medicines or the whatever agents that can be dialyzed because not everything can be dialyzed. So salicylate or aspirin, methanol, ethylene glycol, and lithium. These are the four agents that are dialyzable. So I am on call. I get a call at 2 a.m. They tell me the patient has had bipolar disorder, has been taking lithium, now has committed suicide by having all the bottle going up, the lithium, has had major lithium toxicity. They call me for dialysis, right? Okay. Fluid overload. The patient is not having major urine output. There is always antibiotics, fluids, all kinds of fluid going in, but the patient has real minimum fluid or maybe anuric even, fluid overload. I need to do dialysis to remove fluid off. So AEIOU, uremic symptoms or pericarditis. So uremic symptoms, we talk about it in a second. Yesterday, some of you asked, what is azotemia, what is uremia? I actually changed my slide based on that discussion that you had yesterday. But pericarditis is another indication. So the patient has acute kidney injury, and one day I put my stethoscope on the heart and I say a pericardial rub. You remember pericardial rub is the sign for pericarditis. Time to start dialysis because uremia, accumulation of uremic toxins, give me pericarditis. So, what are the dialyzable substances? Do you need to remember all of this? No, don't know all of them. You need to know the four that I have already told you, and they are in red. The other ones are just for your information and for the reference. If somebody calls me in the middle of the night because the patient has ditch toxicity, I'm going to kill him. It is not dialyzable. Let me sleep, right? These are on the right side, they are not dialyzable, right? On the left side, they can be dialyzed. That's a very common. We get a lot of calls in the past, more probably because digoxin is not used more, but digoxin, we got a call from cardiologists all the time for ditch toxicity. And the answer was that, unfortunately, dialysis has no road. Digoxin is not removed by dialysis. So actually, let me tell you why it is not dialyzed. There are two general rules for clearance by dialysis. It needs to be water soluble. It shouldn't be going into the fat. Second is that not highly protein bound. If it is bound to proteins, it will not be going to the other side of the filter. So it should be water soluble and not highly protein bound. Most of them are uh, fat soluble. Okay. Is it one? Okay, very good. What are the indications for renal replacement therapy in the end-stage kidney disease? You see that sometimes I use end-stage renal disease, sometimes I use end-stage kidney disease. This is the transition between renal and the kidney. So in ESKD, renal replacement therapy is used with uremia. So yesterday, one of you asked, what is azotemia? What is uremia? I changed the slide based on that. Azotemia is the high levels of nitrogenous waste products like the urea thing that we know. Uremia is the clinical syndrome that is based on the azotemia. Because azotemia is prolonged or severe, we get uremia. Basically, when it comes to become a clinical syndrome, it's uremia. So uremia is defined as accumulation of uremic toxins. And you ask me, what is uremic toxin? I mean, you tell me, okay, the patient's filtration is down, so the uremic toxins is accumulating. But you don't tell me what are those uremic toxins? What are those waste products? I will tell you, here they are. There are either small or middle molecule or big. Okay, but do you need to know all of these? Do I know all of these? No. So, which ones you need to know? This is your famous urea and creatinine. Now, based on this slide, you know, are they small or mid-size urea and creatinine? Small. So, do you anticipate they will be freely filtered in dialysis or they will have a hard time to get dialysis? Freely filtered. Yes, exactly. That's very, very true. Okay. What are the manifestations? You told me that uremia is when azotemia, meaning that the waste products have been going up, and I have started to have signs and symptoms. So tell me, what are those signs and symptoms? These are the signs and symptoms, and the red ones are the ones that you and I we need to remember. So the patient who whose kidney is not filtering well, the waste products are going up, right? He's getting azotemia is going up, so he's getting uremic. He starts to tell you that, you know what? I have stopped eating. I just don't enjoy food as much as before, right? So unintentional weight loss. That's what that Mr. Smith was, right? He came 2 months ago and now his weight is lower. Okay. Foul taste in mouth. They have a metallic taste in their mouth. Actually, that's what prevents them from eating. What typical thing that my patients tell me is that I don't enjoy the same things that I was enjoying in the past. Let's say something chocolate. She liked chocolate, and I said, I just chocolate doesn't have the same taste. Decreased appetite we talked about, and fatigue. They are all the time tired. They haven't done much. He's a 41-year-old librarian, we said this guy, but he's all the time tired. That's the time to think about dialysis. That's the time that we say, you know what? This is one of my colleagues always tell us, and I think I agree with him. He says, let's start dialysis when the patient is sick and tired of being sick and tired. Basically, over time, said, you know what? The appetite is not good. I'm always tired. Let's start dialysis. And that's a good time to start. It's kind of a ripening situation. In the past, just 10 years ago, we went by GFR. Whoever had a GFR of less than 10, starting dialysis. These days, we don't do that. This is patient centered. Every time I ask him, every 4 weeks, I see them. So, are you ready? Are you tired? What? And then if somebody can go for years without dialysis, somebody would say, let's start dialysis. I am sick and tired. Okay. GFR is usually less than 10. Sometimes I have dialyzed patients. I have started when their GFR is less than 5, actually, almost no filtration. But if they don't feel that bad, let's go. Okay. So our Mr. Smith, when I told you I put these things in there, he was tired all the time, decreased appetite, metallic taste, to a point that he lost weight 2 months ago, right? So he seems to be getting to a place that, hey, I have a lot of uremic symptoms. Should we start dialysis? You tell him that based on his symptoms, you think it might be time to start renal replacement therapy. He wants to know more about it. Well, principles of renal replacement therapy. And you remember the whole slide, it's a filter, and you go from one side, the blood, the 3 layers you know so very well. Let's remind ourselves, what is this side? This is blood. What is here? Fenestrated endothelium here, right? This one. Then it is what you were saying. What is this one? Yes, GBM. And what is this one? Podocyte. Very, very, very good. Then there are in the tubules we make changes. Urine is made. So we go from the blood all the way to the urine. Okay. So kidney, if you think about it, is a sophisticated filter. That's what we use for dialysis. We need just a filter for dialysis. The whole principle of renal replacement therapy is based on a filter. And believe it or not, I brought for you from US one of those. Here it is. Look, isn't it the same? That's the same filter. That's what we use in dialysis. Okay, the dialysis people gave me this. I didn't steal from them. Okay. And then here is the fun thing about it. If you cut it here, you look at it, these are small fibers here. Very, very small fibers are inside this big thing. And this is how it looks like. Sorry, I will get to you in a second. So this is every fiber, you know, hundreds of thousands of fibers inside one big thing. So inside is the blood, around it is the dialysate that is clean. So we pass the blood and there is a good fluid going on. Exchanges happen between the two of them. And somebody had a question, please. Uh-huh. No, 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 no. This is all made up in the factory. There's nothing about, there is nothing biologic about it. Actually, I have it here. It's a good question you asked. because it's not really brown. It is this color. This is the broken one of these. And these are small fibers. I don't see if you can see it from here. And this is, if you see, you can come later and look at, these are the fibers. These are the fibers. They're so small you can barely see them. Inside, the blood moves, outside the fluid. So these are this is small. Okay? I leave it here for you. You can take a look at it. And there is a code. There's a reason for all. F is Fresenius, the company that makes this. 160 means that if I open each of these fibers that is like a round thing, I open it and put them next to each other, it would be 1.6 square meter. So they call it 160. And NR means non-reusable. In US, it is not allowed to reuse a filter. When you use it, you should throw it away. In some centers, they use it for a patient, they sterilize it and use it for the same patient the next time. That's okay. So 3 times a week, Monday, Wednesday, Friday, they come for dialysis. So you saw how it works, right? Now you have a real one. I brought it for you so you can come and take a look at it. So everything is based on a semi-permeable. That's why I had shown you that filter to tell you at the end of the day, when we are replacing the kidney, we are replacing it. And the fun thing about it is that in the dialysis unit, they call these kidneys. They say, give me a kidney. They're talking about this. Bigger kidney, bigger filter. Okay. So, two methods for clearance. Now that you know how it is working, the filter, we need to know a little bit more. So, when you tell me, Amir, that this is the filtration, how does that happen? One is through diffusion, one is through convection. These are the two methods, or I would say the two mechanisms by which dialysis works. Diffusion, you and I, we know it so well. So you have a semi-permeable membrane here, which would be this. Then on one side, you have a lot of concentration of something. When they're next to each other, this one starts to diffuse to the other side because the concentration here is more than here. What it means is that I have a lot of creatinine in my body. You put it next to a fluid that doesn't have any creatinine. The creatinine moves to this side. BUN moves to this side. Potassium moves to this side. This has a potassium of 4. My potassium in the serum is 5.6. Moves to this side until it gets both 4, right? And this is moving, right? So it's not just giving it. This is moving. Another fluid is coming, fresh, gives, and continues. On the other side, bicarbonate. I have acidosis. My bicarbonate is 17. You give me a bicarbonate of 28. Here goes to this side, right? Diffusion happens depending on the concentration. So from higher concentration to lower concentration, you are very familiar with diffusion. This is what it tells you. Creatinine from the patient goes to the site of the dialysate. Urea the same, bicarbonate the other way. And this is how the diffusion happens, okay? What about convection? If you think of convection as flood. Have you seen when there is a flood, there is a chair going, a car going, a toy going, whatever, all of it, depending on their size, they will go faster or slower. You just, on one side of the filter, you put a pressure. So I have the filter here, and then I put pressure on this side. So everything here will be pushed into the semi-permeable things. The water will come here. Everything that is small will come faster. Some things that are a middle molecule will come a little bit lower, larger molecules lower, and some things never come to this side, like proteins, stay on the side of the serum, right? So in diffusion, you were not giving any pressure. You just were putting the both of them next to each other with a filter in between them. In convection, you are pushing the water. As the water goes, like flood, some things will be dragged after the water, solvent drag, right? And you know, This is a solvent drag. And remember, for example, the RBCs never go to the other side, right? But this is the filtrate. This is water. When the water goes, the small things like sodium, potassium, urea, creatinine will all come to the other side. The most common thing that we use, do you use these French coffee makers? I don't know if you use them or not. When you push it here, the water is going through the coffee and it takes with itself the taste and the small particles of the coffee. It makes your coffee. That's the main solvent drag that I know. Okay. Principles of clearance. Based on what I told you, all of these will make sense. There is nothing to memorize really. It's there. So small molecules easily pass through the membrane by diffusion and convection. But when there are middle or big size, you need the pressure to push them to the other side with the water, right? So middle and large size molecules will be cleared primarily by convection, okay? Semi-permeable membranes remove solutes with a molecular weight of up to 50 Daltons, and the plasma proteins or substances that are highly protein bound will not be cleared. That's why most medicines that are protein bound will never get dialyzed. Digoxin will never get dialyzed because it is attached to proteins, right? It is sitting on the proteins. The proteins will not move, so digoxin will stay on the side of the serum. This is what is trying to say. Nothing to learn here, just to remind yourself that smaller molecules, diffusion, as we go to the middle and large sizes, convection will take over. That's all you need to know. The rest is mumbo jumbo. Modalities of renal replacement therapy. This is the part that I don't think you need to know for USMLE or anything. It's just for your reference. We can use what we call hemodialysis or hemofiltration. In hemodialysis is all diffusion. They are blood-based, intermittent or continuous, and extracorporeal. What does extracorporeal mean in terms of the name? Extracorporeal, what does that mean? We have extracorporeal lithotripsy, for example. Extra means outside, right? Corporeal, body. So here we take the blood out of the body, we make the clearance, we do the dialysis, we give it back to the patient. So the filtration, the cleansing happens outside of the body. That's why they are called extracorporeal methods. Again, I don't think you need to know all of this. This is a little bit too specialized. Diffusion is dialysis, convection is hemofiltration, and hemodiafiltration is a mixture of these two. I think this might be the battery of this because sometimes it doesn't work. So in end-stage kidney disease, not only we have hemodialysis, we have peritoneal dialysis and kidney transplant. We can talk about them a little bit more. So hemodialysis, there are different ways. Again, you don't need to know this. Let's talk about hemodialysis. We said that this is the filter, the one that you saw here. So fluid goes this way and blood goes this way. And very funny thing about it, think about it, each of them has four parts. One goes in, one comes out, one goes in, one comes out. Believe it or not, the direction should be opposite, meaning that the fluid should come this way, for example, the blood this way for the most exchanges. If the dialysis technician makes a mistake and you see they have put it red and it's not here, oh yeah, blue and red, they have put the two sides so that you know which one is which. If the dialysis technician makes a mistake and puts both of them in the same direction, you lose a lot of efficiency. The diffusion will not happen that fast. And you see the difference here also. Goes in, comes out, goes in, comes out. The directions are opposite. This is the filter that you already saw. What is hemodialysis? So this is the fun thing. Think about it. What's the size of your kidney? What's the size? That's the size of your kidney. Your fist. We have two of these in the retroperitoneal, right? This, for 100 years, takes care of the water that we take, potassium, urea, creatinine, erythropoietin, everything. We just replace one part of it, the filtration, and this is the machine that we use. And we use it 4 hours every other day. Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, 4 hours each time. The patient comes to the dialysis unit, is attached to this machine to do it. Here is the fun thing about it. There is a lot of stuff, the source of acid, blood pressure display, this. But at the end of the day, what is this machine all about is what you see there. Which one is that? That's the bottom line. That's the size of me. If I stay next to a dialysis machine, that's either taller than me or the same. So that big thing is all about this. This is all meant to make dialysis, the filtration happening. Just give yourself a lot of credit. You're sleeping, it's working. It's holiday, it's working. Thanksgiving, weekend, it's working 9 years, 100 years, non-stop, day and night to do everything. And this big thing, we have come for decades, we have been thinking about it. We have come up with this big thing that works only on one of the functions of the kidney. So, what are the complications? You want to know what are the complications of the kidney. You don't need to know a lot of it. What you need to know is these two red ones. One of them is that so you are bringing out the blood. It is in contact with all kinds of this stuff and goes back. Obviously, you are increasing the risk of infection in these patients. And it is bad infection. It is blood infection. Goes directly into the bloodstream, right? The other one is intradialytic hypotension. As you're bringing out the blood, some people have volume overload. They don't make any urine, and during the last 24 hours, they have been drinking like anybody else. So they are above by 2 liters. You take 2 liters off in their blood, so their blood pressure sometimes goes down. Intradialytic hypotension and infection are two main complications of dialysis. You tell him that based on his symptoms, you think it is time for renal replacement therapy. He wants to know more. After discussing various options, he opts for hemodialysis, asks you to start the process for evaluation for renal transplant. So, when you want to do hemodialysis, how do I access to blood? I need a lot of blood to go inside this and come out. It's not a normal vein or artery, doesn't give me this much blood, right? So we need to create an access for hemodialysis. So we need a blood vessel with a high blood flow. For example, 500 milliliter per minute. Remember, we have 5 liters of blood. In other words, every 10 minutes, one time the blood has been inside this every 10 minutes, right? So, what are the options for access to blood in in acute kidney injury? We put a catheter in the central veins, right? Internal jugular vein is the most common one that we use. Remember, on the right side, it has some way to go to the heart. On the left side, the tip is directly to the heart. God bless. If you get infection, the organism is directly into the heart on the valves. We can get endocarditis from the hemodialysis. Internal jugular vein, you see where it is. For the end stage kidney disease, it's not a one-time, two-time deal. You cannot just leave something here outcoming. That's for the hospital. This guy wants to live his life with that access. So you need to have a better access. One is a tunnel dialysis catheter, meaning that the catheter is inside the same IJ, but it is tunnel. It doesn't come out like this. We push them back, it comes here. Above the nipple, we take it out, right? So when they take off their clothes, you see that the tips are out. I don't know if I have pictures of that or not. Or we just put one artery next to vein. That needs a vascular surgeon. On the arm, they put one artery next to the vein, so the vein gets bigger, and then we cannulate the vein every time the patient comes for dialysis. Either it is a normal fistula or we need to take a piece of plastic if the veins are not good. We call it AVG. instead of AVF. So actually that's the tunnel catheter. So you see the tip is almost in the heart, goes into the internal jugular, but we tunnelize it under the skin to bring down the risk of infection, and it comes out here. So we use this for hemodialysis. Infection is decreased by tunnelization. AVF, AV graft. This is just for your information. You don't need this for the USMLE. Again, a vein is attached to an artery through a graft. It is PTFE. It is a piece of plastic. And this one, there's no plastic. Just a vein is attached to the artery, and that's where we are going to use that vein after a few weeks that it has been arterialized. So this is a real case. You see on the arm or forearm, there is one, there is another one. You have these two sides that you have cannulated, and that's the big machine. And you see that one part of the filter here. Okay. In order of preference, obviously, we don't love like the piece of plastic. So tunnel dialysis catheter is the least preferred. We like fistula first, graft second, catheter the third, in terms of preference for access for hemodialysis. So for him, you send him to vascular surgery clinic for creation of AVF or AVG, as well as sending him to transplant nephrology clinic for evaluation. What is peritoneal dialysis? I talked about hemodialysis, but I didn't talk about peritoneal dialysis. Believe it or not, our peritoneal membrane can be used as a filter. So every one of us is born with a filter in the belly, basically. This is what I am talking about. This is the belly, and this is the peritoneum, and these are the vessels in the peritoneum. So what happens is that this is peritoneal cavity. You put some fluid in the belly. There are exchanges between that fluid and the vessels that are in the peritoneal cavity. Let's say glucose goes in, BU and creatinine go out. Both convection and diffusion works the for peritoneal dialysis. And if you want to look at it, it is this way. We have a catheter that we have put in the peritoneal cavity, and then we put the fluid in. We leave it for 4 hours. All the exchanges happen. The fluid has no BUN, no creatinine. The potassium is good. Everything is good. So all the exchanges happen. 4 hours later, we take it out. A fresh fluid. 4 hours later, if it is during the day, if we want, we can use a machine at night that pushes the fluid. The patient goes to bed and sleeps, and he's attached to the machine. So it pushes fluid in the belly, stays for a few minutes, takes it out. Pushes the fluid into the belly, few minutes out. So does 5, 6 cycles of dialysis during the night. So this is peritoneal membrane. We talked about it. Dextrose is the one that makes the fluid move. You don't need to know this except for the fact that how do I make the fluid move from one side to the other? What is the agent that is used? It is dextrose with different concentrations. And I put actually the actual things for you if you are interested to know that this is 2.5%, this is 4.25%. So more glucose you give, it is hyperosmolar, takes the fluid out of the patient. So this is how we manage the fluid overload in these patients through osmotic rate. So if you want to think about peritoneal dialysis, if you think about this, you know about peritoneal. This is all you need about peritoneal dialysis or PD for USMLE. The filter is peritoneal membrane. We don't have that. It is intracorporeal therapy because the exchanges happen inside the body as opposed to hemodialysis. It is both diffusion and convection. It can be done intermittent or continuous, meaning over the 24 hours you can do it all the time, or direct or intermittent. And there is no direct access to blood. That's what we love the most about it. But can they get infection still? Yeah, they can get peritonitis. We call it PD-associated peritonitis. This is what I was telling you. If you do it during the day, this is ambulatory. You put the fluid in, the fluid goes out 4 hours later. This is how it looks like. And if you do it at night, this is the machine that does it for you. This is the size of just the fax machine or so. What are the complications of PD? Two things that you need to know among all of these. These are for your reference. One is peritonitis, because you're taking fluid out. There is manipulation of the tubes. At any given time, you make a mistake. Actually, for example, we tell them they can't have a pet. If you have a pet, you are more likely to get infection. Now, people with peritoneal dialysis. And then hyperglycemia is another one, because as I told you, these bags are filled with glucose. Actually, once I made some kind of I would say calculations, each bag of this PD fluid can be like 25 lollipops. So you put 25 lollipops in the belly of somebody and then takes it out, especially if the patient has diabetes, you know that hyperglycemia may be an issue. Just to give you an idea, how many patients are on hemodialysis? How many patients are on PD? How much are we talking about? The blue is hemodialysis, and US is that arrow. The great majority of the patients are on hemodialysis. Let's say 80%. Some 20% or less are on peritoneal dialysis. This says more than 80% of the population. Please. The PD and hemodialysis, yeah. For the same purpose. It is just the lifestyle thing. Think about it. If I am somebody who wants to be independent, I do it on my own. I want to have flexible life. I am a college student. I can't come Monday, Wednesday, Friday, 4 hours sit in a dialysis clinic. So I say I use peritoneal dialysis. I do it at home on my own. At night I go, I hook myself up. In the morning at 7 a.m., I undo. That's it, and I live my life. But if I am a 75-year-old gentleman, has shaky hands, doesn't know how to do PD, I rather come to the dialysis unit. A nurse comes, starts the dialysis, checks my blood pressure. You see the point? So these are two different things. And there are studies after studies to see, is it PD better or hemodialysis? There is nothing better. It's based on lifestyle. This is the catheter. If you think about it, has gone here, goes to the tip of the PD catheter, needs to be in the cul-de-sac. I think I have it. Yeah. This is the catheter. This is out. Do you see it here? That's the best place for the peritoneal dialysis catheter, because all the fluid will be here. So it will be easy for the exchange. Sometimes it moves with the bowels moving, goes all the way subhepatic. We need to give them some. And this is when how it looks like. So do you think they can go to the beach? Can they go swim? Right? It has its own limitations, right? They cannot immerse in water. Okay, basically, transplant is the treatment of choice. Whatever we like, dialysis, PD, or hemodialysis, the best way would be transplant in terms of survival. It has nothing to do compared to dialysis, but obviously, there is not enough organ for everyone. That's why we have to do dialysis. But remember, transplant is the treatment of choice for end-stage kidney disease. I might be wrong, but I think I saw it in one of the questions, Kaplan or something, that it was asking about the treatment of choice for end-stage kidney disease. Remember, transplant is the treatment of choice. It might not be possible for everyone, but that is treatment of choice. And with this, I think we finished our didactic sessions. Tomorrow, as I said, we are going to talk about a lot and a lot and a lot of questions. Thank you very much.